For those I haven't met, I'm John Rice, and I'm delighted to welcome you to this, I guess we'll call it a lunch and learn. And we're, Cammie and I are so happy to be back in Hong Kong. After too many years, we've had a ton of fun. We've gotten to see not all of our friends, but many of our friends. And frankly, we look forward to coming back next year. Before I introduce our two speakers, I also want to call out a special person in the audience, Magdalena Yu, who is here with her daughter Daisy. She was my executive assistant for the better part of 7 years, and with a few other people in the room, kept me and Cammie on the straight and narrow. So Mag, it's great to see you, and thank you for being here. This is a special event for us. This is a special subject because it starts with something that was so painful you can't imagine, and it turns into something that is positive and will make a difference. And I'm going to let Cammie and Mara talk to you more about that. But I can tell you that from a family perspective, what we went through in 2016 was something that no family should ever have to go through. Unfortunately, too many are these days. A lot of that happens in the United States, but not all of it. And that's some of what our speakers are going to talk about. So first, I'd like to introduce my better half, Cammie, who is the only author that the family will ever have. You can be assured of that. But in addition to writing The Flight, which I think you all have a copy of, and is really a tremendous story about her personal journey. In addition to that, this is really an opportunity for her to talk about what she's learned along the way. She's done so much with task force on opiate prevention, education. That's really the message here, is we have to get smarter about this because once you get addicted, if you have that situation occur, it's really hard to fix that problem. So the moral of the story from our perspective was education and prevention. Cammie's been on the Attorney General's task force in Georgia. She's on the DEA task force, Drug Enforcement Agency task force, a federal program. She's spent the better part of the last 6 years being really educated about this problem and what she and collectively we can do to keep other people from going through what we had to go through. And she's joined today with Dr. Mara Schenker, who is a friend, also one of the champions that when Cammie and Mara met, they connected. Mara is the chief of trauma surgery at Grady Hospital in Atlanta, which the problems that come in and could potentially result in a problem later on with substance abuse and addiction. She's also the chief of trauma for orthopedic trauma for Emory University, and a wonderful partner and just a terrific person. We're delighted that she's made the trip to be here with you. So I'm going to stop there and turn it over to Cammie and Mara so you can learn more about what they have to say.
Thank you. So it is so wonderful to be back in Hong Kong, and it's great to see friends and new faces as well. And it's special because my son Christopher, before he passed away in Cambodia, February 26th, 2016, we spent every single day together here in Hong Kong. So it's very symbolic for me to come back and to do all the things that we did on his last 2 weeks on this earth. So go to the next slide. This is my baby. And while some of you have met Christopher and know Christopher, for those of you who don't, look at the smile. If he met you, he hugged you. He immediately got in your space and he hugged you. And he was extremely book smart, disciplined. He wanted to be a Navy SEAL. That was his goal, is to be a Navy SEAL. He was an AP student. I could sit here and brag and brag and brag about how wonderful my Christopher was. And in middle school, he was diagnosed with a colon disease, and it was called ulcerative colitis. And things went downhill, and it just kept getting worse and worse. And his senior year in high school, the doctor said his large intestine must come out immediately. And I said, well, it's in the middle of his senior year. No, it has to come out right now. You're going to risk colon cancer. When you hear that word as a mother, you go, oh my God, okay, we'll set up the surgery right away. Now looking back, would have, should have, could have, would I have done things much differently? Absolutely. He had his large intestine removed, there was complications, and he was on morphine for 70 days, and we went home with 90 painkillers. It was the exact same time that Purdue Pharma had released the wonder drug. I never even thought for 2 seconds to ask a physician, is this addictive? Is this going to hijack his brain? What's going to happen here? And I followed by another prescription. He had a hole in his stomach. He was in pain. I was told to give him to him every 4 hours, and that's exactly what I did. And he went into the hospital with one disease, and he ultimately lost his life with another disease called addiction. Now, the stigma that we have around the world around addiction has got to stop, okay? Silence kills. I hid it because I didn't want anyone to think poorly of my wonderful, beautiful son. So we fought it as a family quietly by ourselves, when you actually need an army of love and friendship and family to get through something like that, right? And honestly, that's how it used to be with cancer and AIDS, right? I'm sorry, but I'm okay on the photos. I'm okay on the photos. Sorry, I don't mean to embarrass you, but it's just a lot when I'm trying to really connect here. Because this is not about perfection. This is about connection, because I have a fire inside of me to warn every single one of you, because you leave here today and you take the knowledge that you have. This isn't a fundraiser. This is about educating you, because you could save a life with somebody that you know. Because my Christopher should still be here today. It did not have to happen. And it took me 2 years to say the word overdose, because I, sadly enough, wanted my son to have a respectable death. I didn't want people judging my son by the word overdose. So, with that, CWC was born because we had to, how can we stop it before it starts? Christopher's brain was hijacked by medication from a hospital. And so how do we prevent it? How do we stop it before we start? And so I thought, what did Christopher need in the hospital? What did I need in the hospital? I need a care coach. We have coaches for everything in our society, birthing coaches, workout coaches, sleeping coaches. But when you're in a health crisis, you have no coach. You have nobody saying, hey, if you're going to be on an opioid, you better taper off very quickly. Or let's look at some other things for pain management that are non-addictive. Let's talk about your anxiety, your stress, your depression, your PTSD, your mental well-being. Those things are important when you're having a health crisis. So then I met a superstar over here, Dr. Mara Schenker. And I'm going to let her talk to you a little bit about how this whole thing happened and what took place after that.
Hi, good afternoon. Thank you for welcoming me so kindly to Hong Kong. This has been an amazing few days with some amazing people, so thank you very much. But I met Cammie. I'll back up. So probably right around the time when Christopher started to get sick, I was in my medical training. And when I was going through my medical training, we were taught one way of treating patients' pain. And so when you learn a certain way, when we learn anything in school, we learned how to do surgery, we learned how to treat people's pain after surgery, and the way we treated pain was, here's a prescription for your pain. And so I was coming up through a medical training really not all that long ago in the grand scheme of things, but with one thing in my toolbox, and that was just typical. So that was how we handled most surgeries. And so fast forward to me starting my practice, and I met Cammie in around early 2019 is what we decided this morning. But I had just started my practice at Grady Memorial Hospital, which is because we're the only trauma center in really the whole state of Georgia, but we get all of the trauma through our main hospital. And I was busy. I hit the ground running. I did about 600 surgeries my first year, and that means like when patients come to our clinic, they're like, well, they want to spend more time with me, and I want to spend more time with them too, but I don't control the amount of people who get injured in a certain day. And so it's just, we have to see everybody who got injured in our clinic. And so they came through our clinic, and at this point, the opioid crisis starts to get a little bit more of attention in the US, but still the only thing in my toolbox from my training, which was not all that long ago, were pills for pain management. And when I'm busy and when I don't have any other alternative, I just don't know what I don't know. You know what I mean? And so I was seeing sometimes between 60 and 70 patients in 8 hours in our office. And so they're going in and out, and they're said this person had surgery, this person had surgery, this person has pain. And so I gave them prescriptions. And fortunately, I had sort of the self-awareness to say, okay, there's an opioid crisis happening, and I am treating people's pain with opioids. And so I started reading, and I read the book Dreamland, which is a fantastic overview of the opioid crisis, and started to talk a little bit about it. And I started to ask around, and I asked my physician's assistants and people who actually are the ones who physically write the prescriptions for my clinic. I said, how do I compare to the other people in the office in terms of my willingness to prescribe? And they were like, well, you sort of give the most. And I stepped back and I was like, wait, I thought I gave the least. And I had no concept of I just really wanted to see people not have pain. And that was the only thing I knew how to manage pain with. And so I said, okay, let me think about this. And so I ended up giving a lecture for the Emory University faculty. And Cammie found her way in the back and was sitting there, and she came up afterwards and she said, hey, can we talk? And I said, sure. And so we ended up coming together, and because I very much had a problem that needed solving, which is I have patients who have pain and I don't know how to help them because I am trained to fix bones. I am not trained to help people manage their pain as much as I want to be able to. So I need to be able to outsource that and find somebody who is an expert in that. And so that sort of was the birth of Cammie's Lifecare Specialist, filled a very significant need that she had for herself and for her son, but was also something that I desperately needed and the nurses desperately needed, is someone to be able to go to that can provide people with additional resources to be able to help them manage their pain. So that's where we are.
Yes. Well, and I really stalked her, honestly. I mean, she got off the stage and I was like right here. Excuse me, you want to go to dinner? Because, to create a new position in hospitals, you have to have data. So we have a clinical trial. It's all on clinicaltrial.gov. It's official. We have tons of data. 70% of the patients that we researched through our trial didn't know they were taking an opioid or what it was. And, I just did a talk here last week, and I had somebody privately come up and tell me that, oh my gosh, a friend of mine, I called and she hurt her back and she told me what she was been prescribed here, and she didn't know it was an opioid. And she got a bag full of them. And so they Googled it and looked up, sure enough. And she wasn't informed how quickly that she needs to taper off. So my point is, it's okay to be your own health advocate. In fact, it's key that you're your own health advocate. When your children go to the dentist to have wisdom teeth extracted, they don't need to go home with 30 pain pills. It's called Motrin and ice. you have to be very careful because there's many young people in treatment centers today that started with one prescription and it came from a dentist. Dentists are some of the highest prescribers around the world. People don't think about that. So the questions are important for you to ask the doctor or the dentist questions and understand that you can become addicted with one prescription. So that's the big takeaway, right? So we have Lifecare specialists at Grady Hospital. We've now moved into other departments. We started in orthopedic trauma for a reason, because that's usually young people's first introduction to opioids, because they've had a sports injury or a car accident. And so that's usually the first time that they're receiving opioids. So we started there strategically. And we have a whole research team now, which is pretty exciting. We just received a grant from the NFL, the Football League in the United States, to do Lifecare specialists with sports injury surgeries. And then we received a $1 million U.S. grant to go into rural communities, rural hospitals, and expand our services. Our goal is to have Lifecare specialists in hospitals everywhere around the world. That's the big goal. But there's two things going on in the country. And what I'll tell you is, I've been in a lot of conversations. Well, we don't have that here. It's everywhere. Do not be naive. It is in every country, okay? So don't be naive and have those conversations with your children, because there's another thing happening. You've got the opioid epidemic and you've got a fentanyl crisis. How many of you know what fentanyl is? Raise your hand. Are you aware that there's a crisis? Okay, and it's killing 300 people a day in the United States. It's the #1 killer for age 18 to 45 in the U.S. now. So if you go to the next slide. So if you look at, it's 50% stronger than heroin. It's 100% stronger than morphine. Now, not to be confused, we're talking about illicit fentanyl. There's fentanyl in hospitals that have a use in hospitals. This is illicit poisoning. It's lethal. It is, if you go to the next slide. They're creating fake pills. You can't tell the difference between one that's fake and one that's real. Pill mills are using these manufactured pill mills that you literally cannot tell the difference between a real Xanax or a fake Xanax, a real Adderall, a fake Adderall. Next slide. And they're targeting our children. And when I say they, the drug dealers aren't on the corner anymore. They're on the black web. They're reaching out to children on social media, young people, all the social media platforms, Snapchat, Instagram, social media, and they make it look like candy. And they are DMing your kids, say, hey, would you like to have some fun tonight? Would you like to dance all night long and never stop? Would you like to continue laughing? They see a kid's going to a concert. They send a note. Would you really like to up the concert to more fun? Then they deliver it straight to the home. I've had situations, I've been with parents that have lost their children. A mother had a sleepover for 14-year-olds. They were contacted on Snapchat. The mom was upstairs, kids were downstairs playing. They delivered the drugs to the home. They looked just like dessert, just like Skittles, like candy. The mom went downstairs, every child was dead. Don't hear about that. Don't even hear about that in the US. And it happened. They took one pill. And that is not an overdose. That's not taking 10 of something. That's taking one pill and it's poisoned. So it's murder. So that's what the DEA of the United States is speaking out and saying our country is under a chemical warfare attack. Is it happening in other countries? Absolutely. And I've even had parents say, well, I've had talks with my kids know better, and I'm just saying don't be naive, keep having those conversations, because the West Point cadets last year at spring break went down to Florida and they tried cocaine for the first time and it was laced with fentanyl. So I know that those parents thought there was no way their kids would do that at spring break. People have been trying drugs for thousands of years. The difference is they're now poisoned. So you really have to have that type of a conversation. And if you go to the next think, this is Narcan. This basically tells your lungs to breathe. It's a nasal spray, and I can pass it around. It's just literally like a nasal spray, like Afrin, and this saves lives. This is going in all the schools in the United States, libraries, airports. It should be everywhere where there's a defibrillator or a fire extinguisher, because that's how often it's happening. If you administer this to someone that you think is overdosing, but they're not overdosing, it will not kill them. They'll be okay. So this is really the lifesaver because it's telling your lungs to breathe. And this amount, if I pour this sugar in this glass, if that were fentanyl, that would kill over 500 people. And it has the potential to create over 1,000 fentanyl addicts. You say, well, why would the drug dealer want to kill? That's one of the number one questions we get. Is why would the drug dealer want to kill their client? If you have a slight drug tolerance for drugs and they get you addicted with just a little speck of fentanyl, you're the best client they've ever seen. You're coming back 10 times in one day. So they don't care about the ones that die, because the ones that they get addicted to fentanyl, by the way, they have a lifespan of a year of living if you're a fentanyl addict. But if they get you addicted, if you've got that drug tolerance, then you're going to be the best client. So we want to open it up for Q&A. We've thrown a lot at you, but again, I don't want anyone to have the pain that I have of not having my child, because there is no worse pain on earth to lose your child. And I do this for him because he sacrificed so much. He fought addiction for 15 years. 15 years. And he shouldn't have had to do that. And I don't want anyone else to have to go through that with your child. Because once you become addicted, it's a daily struggle. Is recovery real? Yes. You can get on the other side of it, but you have to work it every single day. And it has to be a family ecosystem around of support for that person to survive. It has to be treated with love and empathy and compassion, which we don't treat addiction that way. Because several years ago, people were dying with fentanyl, but they were all addicts, so nobody paid attention to it. Now that 11 and 12 and 13-year-olds are losing their lives, that's all on us because we didn't do something when the addicts were dying. So we have to speak out as for humanity to save people. This is our QR code if you want to sign up for our newsletter just to continue to stay educated. In the book, The Flight, the reason I wrote the book was to reach the masses. How can I reach the masses quickly? There's a QR code in the very back with the resource library. There's a great website, Partnership to End Addiction, that has ways to talk to your kids about drugs. A lot of resources for you. And because it's QR code, we can constantly keep it updated. There's also video after every chapter that I just give a little bit of extra content. And I'll tell you, the hire up there took over that book. It turned into way more than I ever expected. And so you all have a copy that you can leave here. I want to thank Bookazine to see my book in a bookstore because it's sold online in the U.S. It was a big deal. I mean, Hong Kong is a second home to me, and it was just the way it's been embraced. It's just, thank you. That's all I can say is thank you. So. And we want to open it up for Q&A. Anybody have any questions for Dr. Mara or myself? Patty, we're going to have one microphone.
Sorry. Yep, we have another microphone.
Okay,
Speak up. It's going up. Patty can speak up.
we've got one coming.
Sort of setting aside the drug dealers, etc. The issue with opioids in hospitals and the over subscribing. So I do understand that there's a big chain here because the pharma companies make a ton of money. The more they sell, and the more money they make. So I get that. But really, I mean, the opioids obviously have some advantage. So they do what they're meant to do. So is the issue simply over? Okay, thank you. Is the issue simply doctors not advising to stop after however long it is, a week or 2 weeks? And was that ignorance by the doctors all those years ago? Maybe, well-founded, etc. But the notion that doctors were sort of letting people go out with 80 tablets, which now presumably would be considered, too many. So what happened there? Because it serves a purpose, but then it got abused, or was it abused? That's my question.
Yeah, thank you. So there, what'd you say?
The lack of training you had.
Oh yeah, no. So coming through, I mean, in the 90s, there was a major push, and I think it's unique to the United States in that we market pharmaceuticals directly to the patients. And so that is a very unique player in this game, is that patients were told that there was this available sort of wonder drug that was going to be able to help them manage their pain. So that was piece number one. Piece number two is also fairly unique to the United States, is that around the time that all of that marketing came up, there was a joint commission which accredits hospital systems throughout the United States in the same way that you check heart rate, you check blood pressure, they commanded that any hospital that's accredited measures patients' pain on a scale of 1 to 10. And even up until this day, you have to put into our electronic health record medications appropriate to that scale. So like 8 to 10, because the nurses want to be given a very specific thing to do, they're told give 2 oxycodone every 4 hours or something like that. If the pain is 4 to 6, you do X, Y, and Z. And so it's still very prescriptive in the electronic health record that is all based on that Joint Commission needing to act upon a pain number. And so part of it too was, my lack of education. So we're coming up in a world where patients are empowered to say that they have a 10 out of 10 pain, and the nurses are responding with, the medications that have been prescribed. There's the direct marketing to patients, but then there's also a lack of education on our part about the impact of the medications that we're prescribing on long-term addiction. And there was the thing that keeps getting cited over and over and over again was a New England Journal of Medicine article that was written by Porter and Jick, I think in the 90s, that said that it was an editorial that was no longer than a paragraph that said oxycodone, patients become addicted to oxycodone less than 1% of the time. And if you look at all of the subsequent medical papers that have been written, they all reference that one. That wasn't a real original article. That was a blurb that was written in the New England Journal of Medicine that became re-referenced as like the gold, so we didn't know. But so that's part of it, is the lack of awareness. But then part of it too is the lack of, you want to treat patients' pain, but you don't know how. And the how that I got was, here's a prescription, but in reality, like with the Lifecare specialists, so we didn't really get into what they do, and maybe you want to talk about that a little bit, but they look at the patients holistically. They expose things that I would never have time to sit down with a patient to ask about. Things like underlying substance use in the past, things like, because primary care doctors have the time, but I get 5 minutes with a patient sometimes because they're there for their one bone complaint and I'm treating their pain for that problem. And so, the Lifecare specialist has really come in and has addressed that last piece of it, which is, the awareness, the patient-sided things, and then, okay, here's somebody else who can help me when I have, now that I know that this is a problem. Mm-hmm. So Lifecare specialists, maybe you want to
And there
elaborate
is
on what
a
they
place for opioids, but it's not, and people that have chronic pain, they think I'm the devil, honestly. They hate me. They're like, you don't care about my pain. No, I'm going to be real with you. I'm speaking the truth. It's not sustainable for you to be on opioids long term, period. It's not. And so now they're coming out with some amazing things, utilizing ice and freezing before they do surgeries. They're doing non-opioid surgeries now. And there's all kinds of electronic technology that they're doing to utilize pain. And we're including that in our clinical trial of non-addictive pain management. But yes, there is times when you do have to have an opioid, but people are not being told how fast you need to taper off. And that becomes the issue. Anybody else? Question? I know there's yes, Karen.
Thanks, Cammie, for sharing this story. So I have 2 questions. One from
What happened to the mic?
What are students being told about managing pain? I mean, I know they're taught like 10 minutes on menopause and, stuff like that. What about things that changed since you were at school? That's my first question. And the other question, Cammie, for you is, I shared over lunch a story of my son last year who was, after shoulder surgery in New York City, just given a prescription for 60 oxycodone, which thankfully he took none. Why does that still happen? Given everything we know, given all the publicity, given the Netflix show, given the Hulu show, why are they still doing that?
It's a great question. And if you haven't seen Painkiller on Netflix, that's a very good realization of what happened. There are a lot of books, there's a lot of shows. Dope Sick is another one, where they explain the history of what's happened. Unfortunately, money is the base of it, and incredibly the case always, but that is the problem. I will say prescription writing has gone down in the U.S. because they are monitoring doctors prescribing, and they will red flag doctors now. It's all a database, and every state's database is connected. So the prescribing has gone down a little bit, but not to near what it needs to be. And it's a great question. And that's why I feel like I need to speak louder and louder and louder, because people don't know what they don't know. And you don't think to question a doctor. You just don't. Now, I love this one, right? Okay, and I'm not trying to slam all doctors, but you should be able to ask your doctor a question. Do I need 40 of these? My husband's had 4 hip replacements. I'm in there battling with them, going, why are you giving him 40 Oxycontin? He's not going on with 40. Sorry, it's not happening. There's other things to do besides take that addictive medicine. And they're not teaching in med school.
To answer your question, we actually did a study on that recently where we interviewed a bunch of the current medical students to just ask them what they knew about pain management, about the opioid crisis. And we did it as a qualitative study, which means you ask people questions. They give you their responses, you record it, and then you import it into a software system, and it gives you themes as to what they're saying. And the general theme is they know about the opioid crisis, but they do not know what to do with pain now. And so that's the challenge we're facing now, is that they're aware, but we still don't have a great alternative for helping people manage their pain, if that makes any sense. And there's not, the people who are prescribing the most number of opioids have probably the least number of things in their toolbox. So like there are people who specialize in pain management in the United States, and we have both acute pain management, so people who help right around the time of surgery, and then we have chronic pain management, so people who are on long-term, have chronic low back pain, something along those lines. But we have 2 different specialists, but there just aren't anywhere near enough of them. And they are also not trained on the behavioral side of things. So what other, anxiety management and uncovering a lot of the others. So it's a big problem. I wish we had one phone number when somebody called the hospital and said, I have pain, that you have one person in the hospital who's sort of a pain person, and they help manage those. But the problem is they can call my clinic, they can call somebody else's clinic. And if you were prescribing, like Cammie said, under a certain threshold, you don't have to report it. And so you could get it from, like, if somebody comes in for me, they may break a bone, but they may also have abdominal injuries. They may also have, they may see 5 or 6 different specialists in the hospital, and they can call all of our offices. And if it's under a certain threshold, we would never know that they got opioids from the other person too. So we have a long way to go when it comes to education.
The other thing with the Lifecare specialists, we were able to start the trial during COVID. So it was amazing because families weren't allowed in hospitals. So there was a 26-year-old girl that had to have her leg amputated, and she couldn't have her mom there. And so I said to the Lifecare specialist, don't leave her side. Like, stay right there with her. A lot of times when you're hurting, you need a listening ear. Do you know if you validate someone's pain, it statistically makes your pain go down just a little bit just by having validation, by saying, I know you're in pain. I'm going to be right here with you. Just to have that helps somebody when they're in a health crisis. So the Lifecare specialists have all been trauma certified, and they learned these techniques to deal with anxiety, stress, depression, and PTSD. And they're simple skills to do at bedside, because they need to be simple. If you're having a panic attack, I don't need to tell you something rocket science to do, because you're not going to be there. Your head's not going to be there. So they're very simple techniques that we teach at bedside to distract the brain, that gets you to stop thinking about the pain that you're in. And it helps. So, and again, like I said, a lot of times they just need a listening ear and some empathy and compassion. So that's what we hire on. So it's really amazing to see the difference in a patient's experience when they're going through that health crisis. If Christopher would have had that, if I would have had that, you know, somebody telling me about the dangers of the medicine he'd been given, he'd still be here. And so that's the importance of the role.
Hi, thank you very much. It feels like there needs to be more done, though. My understanding is that in a lot of other countries like Europe, they start with different painkillers and they only move up to the oxycodons if all the others don't work. Maybe that's not correct, but that was my understanding. And that's one of the reasons we have such an issue in the US is because we start there with the best. So has there been any discussion with the FDA or with the payers about not reimbursing for oxycodone until you try Tylenol or whatever? And I know I'm simplifying it, but it just feels like there's got to be more we can do here from a regulatory standpoint as well as an education standpoint to try to address this, because as you said, it happens in all other countries, but it feels like it's so much worse in the US. Now maybe I'm wrong about that, and please correct me if I am, but and how can we help make these things happen if that's right?
So I had a meeting initially, because I met with over 100 physicians before we did this clinical trial and med school, deans of medical schools. When I went up to the federal government, these PhDs pulled me aside and they said, listen, it's only going to help if it comes from the private sector. If you looked at AIDS in the United States, nobody cared about AIDS until the boy in Indiana and the mother. If you look Mothers Against Drunk Drivers, that changed the law. If you look, it has to come from the private sector. He's like, don't expect it to come from the government. He said, every time you get a microphone, speak in it. And so that's all I needed to hear. But that's truly what I think it takes, is it has to come from the private sector, and we have to vote the right people into politics. Amen. There's a whole lot of things, but it's like a tentacles. There's so many levels to it, and it isn't simple. But you bring up a good point. And I do think the U.S. is probably the worst. I think we consume 80% worldwide.
Well, I think part of the problem with this, too, is the game keeps changing as we're playing it and trying to fight it, unlike AIDS, unlike a lot of the other crises that we faced. And that now, so if you look at the curves of prescribing, for example, that's leveled off. So I think, yes, there's still people who disproportionately overprescribe. I think because that curve has leveled off, we don't manage people's pain appropriately. We may give them fewer pills, but we're still not appropriately managing their pain. So that's, problem one, but that's leveled off or dipped to some degree. Heroin was the second wave. So the prescription wave came first, and then the heroin wave came second. That's also leveled off because that was a direct switch from the prescription opioids to the heroin. But now the new game that we're playing this third round is the fentanyl crisis. And so that's a very different animal, because people, like, games 1 and 2 are intentional. This one is inadvertent. And so there's a lot we need to do. And that's in my mind, like, we need to treat people's pain. That's problem number 1, which is what the Lifecare specialist addresses. But we also need to figure out and get ahead of this next wave from a fentanyl crisis standpoint. So I don't think government regulations of the way I prescribe, I don't think that's, for a number of reasons we can talk about, I don't think that will work. Mostly because we have to address pain disparities too, and some different racial and economic groups get prescribed more and less, and so there's a lot of muddiness when it comes to that. But we need to figure out how to get at the fentanyl crisis, and how do you get Narcan around. I mean, one of the issues with even putting it with like defibrillators and with fire extinguishers is that 70% of people who overdose, and correct me if I'm wrong there, overdose alone. And so how do we detect somebody's overdose just, through, and I won't talk about wearables too much, but through wearable technology? Like, is there an opportunity to integrate technology into the detection of an opioid overdose so that you can send people out to help them with Narcan sort of immediately? And so that's, I think, where the biggest opportunity is.
I also think, it's interesting. Like I said, I spoke last week at the FCC, and somebody told me afterwards they went to the local pharmacy here and they asked for Narcan, and then they felt really like the pharmacist was judging, like, why do you need Narcan? And what's going on? And then that person said, well, And she said, Cammie, I really did feel stigmatized, so I just said, I'm a school teacher and I need it for school. She goes, I lied because I felt like he was judging me. He was looking at me weird that I asked for Narcan. And, you know, and in the U.S., it's over the counter, but it's behind the counter and you have to ask for it, you see. They are literally putting this in vending machines across the United States and telling everyone that they should be carrying it. So, you know, I don't know the situation, but I did get that story about here in Hong Kong that they really felt stigmatized asking for it because they thought, oh, I'll just pick up some since I heard you talk. I'll just carry it in my purse and have it just in case. The stigma is real. And so that's why we got to talk about it. You got to be open about it because we all might know somebody that's addicted to something right now, fighting something. And they're doing it alone because they're worried of the judgment and looking good. Or that kills people. Silence is deadly. Got to get rid of the stigma because no one wakes up in the morning and says, I want to be an addict. I want to live that life. Nobody does that. They have root cause trauma. Something's happened that they're self-medicating in most cases, in the majority of cases. So, you know, we got to break the stigma and talk about it and be open to do that. Anybody else? Yes.
Hi, I have a question. I'm reading a very difficult book right now. It's by Matthew Perry, and you know how we don't know, right? We still don't know why he died, whether it's officially he overdosed or he committed a suicide. But, you know, I'm reading that he was hospitalized, rehab. He went to rehab 16 times, spent $9 million on, you know, trying to help himself. And they say that unless you want to help yourself, no one can help you. But nothing helped him with all the friends and everybody he had. So I have 3 sons. 2 of them are in the States at school, and 1 is still here. So I have maybe it's a silly question. Do boys have more chance to be addicted than girls? Or boys are under more danger from the drug dealers than the girls? And in Matthew's case, do you think rehabs don't work, or how does it work in the state? Because in Hong Kong, in Asia, we don't have so many rehab centers. We don't believe that much into going into psychotherapy or so. And you said it comes from loneliness. Mm-hmm. Here we have a lot of family members, everyone around, right, for help. But there, my boys are alone.
We do a risk assessment, and there are people more probable to addiction than others. It's a DNA thing, right? You could probably explain that much more scientific than I will, than a DNA thing, right?
Probably not.
Okay.
Pretty good.
Okay. Because some people will take an opioid and go, oh my God, this feels like honey. Like, I feel so good right now. Wow, this is dangerous. I better stay away from it. And there are other people, my husband being one, he's like, I don't like it the way it makes me feel. I don't want to take another one. You know, so there are people more probable to addiction, I think, than others. I think that is a DNA. Why there's not a study around that? I don't think it's more males than females, no. And all the treatment centers that we did with Christopher, there was probably an equal amount of males versus females in in that. Treatment centers, to me, they've popped up everywhere in the United States because there's opioid settlement money going into every state because everybody's lost the lawsuits, all the pharmacies, all the pharmaceutical companies. So there's billions going into each state. They haven't exactly figured out what all to do with that money yet. I'm trying to help them with that, Libby, Lifecare specialists and all that kind of stuff. But treatment, I mean, there are some good. Partnership to End Addiction, Hazelton Betty Ford, there are some good ones. You really have to do dual diagnostics. Like, you have to look at the mental side, the mental well-being as well, about what's the root cause down there. Why are they self-medicating? Did they get addicted because of a health crisis, or are they self-medicating to numb something that happened? An abuse or this or that, you don't know. And I think that has to be hand in hand when you're treating addiction, is really look into the root cause of what they're trying to self-medicate on.
I'm just curious to see how you would roll this out. Have you thought about how many you would need in a hospital and all that money that you just talked about that be used in that way?
It's a great question. So Harvard Business School is doing a case study on the life care specialists right now, so I'm super excited to lean on them because they said, well, we need to know what's your number one concern, and it's scalability. I know that we need a big horse to ride. It'd be great if it was an insurance company. We need a billing code, to bill for the services. But what I will say is in the US, if you're in the hospital and you get discharged and you come back to the emergency room for pain management within that 30-day window, the insurance doesn't cover the bill. The hospital has to eat the cost. So if 2 people don't come back to the ER for pain management, you've paid for that Lifecare specialist for a year. So it's a no-brainer. It's not like a super expensive payroll position for the Lifecare specialist. And we're not good at preventing things, and putting money on the preventative side, because it's a rounding error when you really look at all the savings that you have from not causing someone to become addicted in treatment centers and so forth. So I'm hoping the big horse will be an insurance company.
And there's also multiple similar models for like roles in health systems in the U.S. So there's the child life specialist, which is in the pediatric hospitals, and they are there, and those are paid for in the hospital. They actually cannot bill for their services. So I think in that setting, the hospitals have realized the value, even if they can't assign a dollar figure to it. They, from a patient satisfaction, patient wellness standpoint, they fund these roles within, and there's over 2,000 of them around the country. The other one's lactation specialists, so newborn mothers, and they have a very different model when it comes to reimbursement. So we've looked at ways of trying to scale this because we think it is so valuable. But as one of my hats that I wear is as a hospital administrator and having to show a return on investment for various things that we do, and this is a very hard one to quantify because you can't. Besides like the impact of decreasing your return to the emergency room, they don't really think about that or care about that. They care about patient satisfaction, but they really. That comes into the preventive side of things, like how do you assign a dollar figure to preventing something that may or may not happen down the line. And so we really need to subscribe to one of the other models when it comes to reimbursement, because it's going to be a hard thing to justify within our health system. But that being said, we've done that. Our hospital system pays for a few of them, which is in a few years, which is great.
Yeah, we got the money to start the clinical trial, and then Grady Hospital hired them. We said at the end of the year, if you don't find that it's valuable, and they hired all of them. So we were like, yay.
I'm just curious about the life care specialists in terms of what kind of background or training they have to be able to, to provide the service and the care. And the other question is actually around like alternative, I guess, medicine in terms of like helping with the pain management. I'm not saying you in particular, are people looking into that more seriously, I suppose?
Yes, we're always looking at new things to add to the toolbox. We do music therapy, we do aromatherapy, we do the techniques I talked about to deal with anxiety and stress and panic attacks. We're always looking, because your pain's going to be different than your pain, and dealing with his pain, he might like one way, but you might like something else, right? Great question on the training. So we've also partnered with Mercer University. We're doing an online curriculum that we're launching at, I think, January 2nd. And it'll be an online curriculum. And then there's a piece that CWC does in person. I had to push back, and I had some debates with some doctors. We have an amazing CWC advisory board of medical staff, and I didn't want it to be required college degree. And the reason why is because we're going in rural hospitals where I wouldn't be able to find candidates that have a college degree. And honestly, you're born with what I'm looking for. I'm looking for compassion, empathy, a listening ear. I can teach you the other things to do with the online and the in-person. And so everybody that we have at Grady, they do have a college degree. It's been a good place for residents that want to be doctors because they get that patient experience. They learn about opioids. They learn about addiction, substance misuse. They learn all of that before coming to a doctor, to become a doctor. So I think it's actually making better doctors to be a life care specialist for a couple of years. But in rural, I need to be able to hire in that community a trusted individual, and I'm not going to find college grads there.
And I think to add on that, beyond the life care specialist, which provides a very specific niche, we also have, so I'm in the process, and what I was working on the flight over is of reinventing the way our entire approach to musculoskeletal pain, so bone and joint pain in our health system is approached. So if somebody calls their primary care doctor and says, my shoulder hurts, right now and everywhere in the United States, and I don't know about elsewhere, it's so fragmented that it could actually be coming from your neck, but it might take you 9 months to go see the neck specialist because no one was able to diagnose that, hey, that shoulder pain came from your neck. But as part of that sort of hub and spoke model that I'm creating, we're going to have people who work on the preventive side of things. So, and we're going to have I hired somebody recently who does acupuncture. And so less traditional things that I did not learn about as part of my training, but I keep asking people, hey, what do you know? What don't I know? Like, how can I better take care of patients when I need to figure out how to navigate them through a very complex health system to give them, the appropriate care that they need. And some of it is definitely prescription opioids. Some of it is acupuncture. So a lot of it is the life care specialist model, but there's still stuff that I'm trying to learn to make that whole process better for patients.
And an example, it's called VibraCool. So like when you have knee replacement or knee issues, surgery, and it's ice and it's combined with vibration, and you have both of those things that, again, hijacks your brain from the pain. There's all kinds of different little gizmo technologies that are coming out to deal with pain, which is a good thing. Anything else? One more back there. Oh, here. There.
Mara, you talked about the marketing of the pharmaceuticals. I remember being in London about 15 years ago, speaking to a friend of mine from New York, and he started telling me how for 10 years he was addicted to pills. And he had this very successful business. And I was looking at him, I was very confused. How could you run a very successful business on pills? And he started looking at me very confused, saying, what don't you understand about this? And eventually I said, but how can you run a business on ecstasy? And he looked at me and went, no, man, I was on painkillers, I was on Vicodin. And then he explained to me that when you call a dealer in America, they turn up with prescription drugs. And I remember thinking at the time that if that happened to me, I wouldn't have a clue what I was looking at because we don't know the brand names. We don't get marketed to. So is there any work being done to stop the marketing, the regulations?
Cammie actually probably would know that better than me, but one of the things I watch CBS Sunday mornings, one of my favorite television shows. I cannot watch it with the commercials because 90% of CBS Sunday morning is pharmaceutical marketing. And we even see this now with Ozempic. Like we were talking about Ozempic yesterday, and I was like, they have to be very careful with the marketing of Ozempic because I've seen large success stories with Ozempic, but I've also seen some people who are losing muscle mass at like an extremely high rate that we don't understand. And we're very quick. Now everybody's jumping on the Ozempic train. And I don't know anything about Ozempic because I, again, fix bones. But that comes in to highlight the fact that, no, it's definitely not any better because Ozempic's the perfect example of why not.
Mm-hmm. No. Yeah. Money, 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 money. Yeah. It's unfortunate.
Tobacco industry eventually got pushed out. Can you see that possibly happening?
So we actually have worked with somebody she worked on the FDA labeling of tobacco. She's at Georgia State, which is right down the street from us, because there's a book that's written about how the whole tobacco process changed from an advertising standpoint and then actually from a prescription warning or a warning standpoint on the labels. I think, yes, probably at some point that will, but the rules of the game have changed at that point. And so I think it's less the direct-to-consumer marketing. Like that will be another drug that has another problem down the line. I think this cat's already out of the bag when it came to marketing because you can't market this.
There's a question back there.
So I've actually led that. That's a great question. It's not standardized.
Repeat the question.
Oh, yes, sorry. The question was, has there been work from a governmental standpoint on, and correct me if I'm incorrect in paraphrasing this, a governmental standpoint on regulating the amount of, or prescribing practices, I guess, or best practices for prescribing. I think each institution is handling it differently. At the Hospital for Special Surgery in New York, one of my faculty came from there recently, and they've done a great job standardizing it. We have done it in our health system as well, where we say when this person has X problem, this is the pills that they get. But I can tell you, last week I did that probably 5 or 6 years ago, before we had even met, and that had not trickled down to anyone outside of orthopedics until last week when somebody said, "Do you have a standard prescription protocol?" And I said, "Well, yes. I don't understand why we can't adopt this system wide." Unless we had a single person who helped manage the pain and who was fielding all the phone calls, particularly when you're training people and they're the ones answering the phone calls whenever they're being when somebody calls with pain, that person may not be familiar with the protocol. So long-winded way of saying no. there's it's so, that's the problem, is the healthcare system is so fragmented that it's so hard to pull people together. And my hospital is very unique in that it's a big hospital, but our leadership is really good. And so we get a lot of people on the bus really quickly when it comes to big change that needs to be made, but it's still hard.
But in New York, I will say that HSS, because all the doctors work directly for the hospital, when they put that protocol in place, 1 year they had a 1 million pill reduction in prescribing. So the model would work if they would institute. But if you don't have doctors working directly for the hospital, most don't like to be told what they're supposed to prescribe. They might not want that call on a Saturday saying, "I'm in pain, I need more pills," kind of thing. It seems to be the situation. I'll let you answer.
No. I mean, there's some people that, again, you can do direct marketing to physicians, not specifically for, I guess there is still some pharmaceutical. There's no incentive whatsoever. It's just
There used to be, though.
There used to be, yeah. And there still is in other parts of healthcare. Like, you can still get wheeled and dealed by the by implant vendors, for example. So, like, for if I'm using a particular plate and screws, or I'm using a particular this, like, there's still a lot of that, but less so in pharmaceuticals now.
And aren't there a lot of doctors here in Hong Kong that have pharmacies within their office?
And they love handing out the list. It culturally here, if we don't walk away with a bag of pills, people complain.
But I have a question. When I hear about, I have a question. So, do you think the awareness also should? I don't know whether it's awareness or education, but when I hear the word pain, of course there are, some surgeries that. It's so major that you do need something. But I feel that a lot of times now in the generation of comforts, convenience and all that, and where, you go to the dentist, they'll say, do you need a few more anesthetic injections so you shouldn't feel any pain? But really, pain is, it's a big spectrum. So when you ask people, do you feel pain? They go, yeah. But maybe that pain's just like a 1 out of 10 pain that needs a 1 out of 10, management versus a 10 out of 10. So how do we know, how can we in some ways, sort of
toughen up?
Yeah.
Well, we're looking for the answer to pill, I think our society has been trained definitely in the U.S. to look for an answer in the pill, and that we're not supposed to be in pain, when actually the pain tells your body where to go to heal, and that's a lot what the Lifecare specialist does prior to surgery. Now we're on telehealth with them, and we set an expectation. Hey, you're having surgery on your leg. You're going to have a little bit of pain, so let's expect that. But it's also going to tamper off. It's going to, it's going to hurt this day, and then day 2, then day 3, and then you're going to be fine. Yeah, and just setting that expectation, having that conversation, I think helps prior to surgeries when you can do that.
Well, and I can give you a very specific real example. So I left for here Tuesday night, and Monday I saw like 50 people in clinic, and it was crazy. And I had one person who had previously been in a car accident. She had, I won't get too graphic, but had a horrible injury to her foot that she could have easily lost all of her toes, had a femur fracture that came out through her skin, had a skin graft, multiple like reconstructive things on her femur. That girl I said to her, you can walk today. And she walked out. And she was like, I'm fine. And I'm like, dude, you are the toughest person I've ever seen in my life. Like, I need to channel that and make it and have you come and help other people. Go 5 minutes later into the next room, and this guy was, the family was from Brazil, and the family had flown up from Brazil, and he was lying on his girlfriend's lap, and she was petting his head, and I was like, oh my God. And so I was like,
please stop petting his head?
That's a start to a day. And I was like, and I sat down and she was like, he shouldn't have any pain. And I was like, I'm sorry. He got hit by a car last week. And I don't say it quite that, insensitively, but I was like, getting hit by a car hurts. But the problem is that whole room, and it was my PA who had been with me to every room, my physician's assistant, she walked in and she was like, they are so tough. And it's because everybody in that room, mom who flew up from Brazil, dad who flew up from Brazil, girlfriend who flew in from Belgium, were sitting there and were like essentially either physically or mentally petting the guy and encouraging him to just not be well. Like they were encouraging him to be the sick version of himself. And I walked in and I was like, you've got to change your mindset. Like like you've got to walk. You've got to put your leg on the ground. You've got to use this, yes, you have a really bad situation. I'm sorry this happened to you, but like, we got to move forward. And I needed everybody in the room to gather around and help that. But then I go to the next room and somebody else has a very different manifestation of their pain. And so that's the challenge from my side is I tend to be, very open-minded, and I spend a lot more time probably with my patients than a lot of my partners do because I am so invested in this concept. But like, it's really hard to walk in and be a psychiatrist / orthopedic surgeon. Like there's just so much happening in these rooms. And I do the best that I can as one person who's trying to manage a lot of problems.
In the United States, there's a nursing crisis as well. And so a silver lining is we've been tremendous respite for the nurses, and they call us their lifeline, and that's been great. They got somebody pressing that pain button, they call the Lifecare specialist, and it's because the nurses just absolutely do not have the time to deal with the patients. So that's been a silver lining we weren't expecting, is actually surveying the nurses and getting great results there. I know, is there any more questions? Because I think we are we at time? Absolutely. I'll sit here all day, so.
Have teenage kids or kids in their 20s. So, obviously you've said we should be speaking with our kids, and I think we're all trying to have that conversation as much as possible, but is there anything else you can suggest to us? Do, don't do, keep your eyes open for, don't keep your eyes open for, so that we can hopefully avoid having our kids, and as you said, it's two different issues.
It is.
There's the prescribed issues, and then there's this illicit fentanyl, which I hadn't appreciated. I knew it was bad, but I hadn't appreciated the microscopic amounts and how big that is. So anything you can tell us to do, please, we'd love to hear.
It's a great question. So another hat that I wear, I've been working with youth for, 20 years, and I chair another youth organization. And what we're doing in the U.S., and I'm going to be talking to Michelle and Libby of bringing it over here, but we have a youth care coach certification where we're teaching young people, because it's really best for a young person to tell another young person and not for it to come from us. So it's peer-to-peer taught. And so that's what we're launching in the U.S. And it teaches you about the opioid epidemic, the fentanyl crisis, and simple mental wellness skills, because I think all of our young people are really stressing at a time now because we're stressed, So you imagine how they are stressed. It's hard times, everything that's going on in our world. So we do have a youth care coach certification. Aside of that, my personal opinion is, if you've got a godmother or a neighbor or an uncle or an aunt that can tell your kid, it's going to be much more, it's better received, because they don't listen to parents. They just don't, right? If we're being real. Oh, Mom, stop it. I already know. You know what I mean? Or Dad, please, I've heard it. But if you have somebody else that they really look up to and they really respect, that's who you tell to have the conversation. And you don't want to be a fear monger, but it's a fact There are so many college kids that think they're getting an Adderall, think that they need an Adderall to stay up and study for an exam, and it has one speck of fentanyl, and they're literally dead. And I'm not being a fearmonger. It is happening. And not just in the U.S. colleges, it's colleges around the world. So understand that. And if, we need to get some personal stories that we can give that you show. There's a Facebook group of over 40,000 mothers. It's called Lost Voices of Fentanyl. It's page after page after page of 15, 16, 17, 18-year-olds gone. It's sad. So, that would be my recommendation, is have somebody else in the family have the conversation and maybe give them something to read so that it's not, you're not being a fearmonger, you're just wanting to educate them about what's going on in the world. Because you don't want to think, oh, it's not going to happen to me. Because all these moms that I connected with, they all thought that. They all thought that. It would never happen to my child. And you need to care about it even if it doesn't happen to you. Right.
Yeah, and I think one thing that as women, we all, when we were growing up, they said never let your drink out of your sight. And I think that stuck with all of us for the most part, is don't let your drink out of your sight. But, if you just have to give people resources. So you can buy that fentanyl testing strips over the counter, right? So I think it's telling people not to take anything that they were given that doesn't come from a doctor. And if they are going to take it, here's some fentanyl strips that you can test to make sure there's not fentanyl in it. And then again, don't let your drink out of your sight. I'll give you a very real example. I was at a wedding a month ago, and my partner, who was an ex-military, he was a special operations helicopter pilot, left his drink somewhere, picked up somebody else's drink, and I think there was ecstasy in it. And he came back, and he was a completely different person the extra 1 hour that I had left him at the wedding, and when he returned from the wedding. And so that afterwards, I was like, dude, do not let your drink out of your sight, because you don't know what's in it. And he was lucky that it was probably ecstasy, which is, not good.
Anybody else? Thank you all so much. Leave here and tell people that you know. That's the main thing that I would love, is just to educate everybody that you know about what you learned here today. And we would just love for you to follow CWC from a social media, because that's where we're really continuing to educate and update people on what's going on social media. And that's why we're here. And we're coming back in May. Thank you. Thank you, Cheryl, for making this happen. Thank you, Libby. Libby, stand up, please. Libby, Cheryl. Thank you both so much for getting the crowd here. We really appreciate you. I love all my friends here, and I love meeting some new friends. It's great to have you all here. Thanks.